Okay, so our next update will be on the integrase STRAND transfer inhibitors related changes in BMI and risk of diabetes. Prof, now we have dolutegravir, an integrase STRAND transfer inhibitor as our main drug for first line, and it's even in second line and in our third line. Are there some side effects or that we should expect with the use of dolutegravir?
Thank you very much. I think we are familiar with particularly the dolutegravir and the associated uh, increase in appetite, increase in weight, and in some cases, the likelihood of morbid obesity. These are the prices that I think we may have to pay for having very useful antiretroviral agent on our menu. And I think looking at the data around the toxicity around the INSTI and what we can do to avert it is subject that is very germane and is good that people are having data around it that can inform policies on the continued use of INSTI as primary agent in the first antiviral therapy.
Yeah, thank you. Yes, with the use of integrase transfer strand inhibitors, we have to look out for some of these things because I recollect from the torpedo study, these were some of the things we did when we were introducing it into the country. So integrase transfer strand inhibitors have a high efficacy for suppressing viral HIV, and we have known this, and they have a high genetic barrier too for developing drug resistance. So they have been recommended as a preferred first line, second line, and even in third line, particularly in our own guidelines and WHO. So it's been linked with, its use has been linked with weight gain and treatment emergent obesity, as you rightly said, and possible association with weight-related comorbidities such as diabetes. Body mass increases index increases have also been associated with high risk of diabetes, as we know. As patients have a high BMI, their risk of developing diabetes increases. So this study compared the association between the BMI and risk of incident diabetes between those that were taking INSTI and the non-INSTI based regimens, or INSTI and non-INSTI based regimens. So essentially, this study reviewed and it's again from what we call the RESPOND trial, 19 cohorts from Europe and Australia. And it had over 30,000 PLHIV, and they were followed up. And they collected demographics, ART treatment history, blood pressures, comorbidities, and lab parameters annually. So part of the exclusion criteria for those that had diabetes were excluded. And in terms of, they did the CD4 cell count and the HIV RNA, 12 months, and then before they were taken. And they also had more than at least 2 BMI measurements during follow-up. And in this study, diabetes was defined as a random blood sugar of greater than 11.1 millimole per liter, or glycated hemoglobin of greater than 6.5%. Again, if patients were taking anti-diabetic drugs, they were, it's obvious that they are diabetic, so they were excluded. So Poisson regression analysis was used to assess the association between BMI, current INSTI use, and current TDF/TAF use, and their interactions on diabetes risk. sensitivity analysis too were conducted using different fittings of ARV and BMI on diabetes. And of course, they also plotted a Kaplan-Meier plot of diabetes events among those that were on NSTay and those that were on non-NSTay users from the start of the drug use class to assess any form of outcome that was there. So the results. So the figures here shows the predicted risk with 95% confidence interval per 1,000 person years of diabetes for DM, okay, among those that used INSTAY and then those that didn't use. But they had a lot of adjustments. They adjusted for sex, age, and ethnicity, blood pressure, and so on. And among those that were using the integrase inhibitors, about 12 of them were taking 12% were taking raltegravir, 60% were on dolutegravir, which was the major. Another 28% were taking others, L-vitegravir with cobicistat, bictegravir, and then cabotegravir. So these were the INSTAY that were used. So in terms of the predicted risk of diabetes by current INSTAY use and BMI, you can see that those that were on INSTAY, they had a higher predicted risk. That's the black lines. As they also had, as the BMI went up, their also predicted risk was also quite significantly higher than those not on INSTAY. Okay. When we looked at the individual INSTAY use, they found raltegravir and dolutegravir to be associated with the increased risk of diabetes. Okay, and the cumulative exposure to INSTAY showed the association to diabetes only after 1 year. So before 1 year, they did not develop. Those that were treatment naive, INSTAY use was not associated with diabetes risk compared to treatment experienced and INSTAY use. So it meant that the use of INSTAY going over 1 year was associated with development of diabetes. And when we looked at the Kaplan-Meier, when compared to those on PI or NNRTI, those on INSTAY had a higher chance of incident diabetes. That's the main thing from here, particularly after 1 year. So our take-home points. So current use of INSTAY was associated with an increased incidence of diabetes compared with PIs and NNRTI. It appears the risk increase with INSTAY is not dependent on the BMI from this finding. And little difference in DM risk between TAF and TDF users, and the effect did not increase with INSTAY use. Okay, so the diabetes incidence, whether they were on TAF or TDF, that didn't really matter. So the important thing is we need further studies to look at the possible mechanisms that is resulting in this diabetes among INSTAY users. And
thank you very much. I think that is the point. The mechanism that relates the use of INSTAY to hyperglycemia. I'm very happy to see that there's a difference with the risk of incident diabetes depending on the type of INSTAY. And it's like dolutegravir is more associated with it, yes, together with L-vitegravir, but cabotegravir appears to be less associated.
Yes.
So the good point here is that if tomorrow incident morbid obesity, hyperglycemia becomes an issue, yeah, I'm just thinking ahead of time. We have alternative INSTAY
to fall back on.
Yes, if this, that, I think we need to emphasize that more people should look at the data so that we can replicate this. And that will tell us that INSTI will still be very relevant. And then when DTG is becoming an issue for some group of people, cartographer or some other, yes, might actually come in handy. I think I read somewhere what the mechanism of hyperglycemia may be, particularly with DTG, the receptor that brings in sugar across the cell membrane, GLUT4 protein, is inhibitable by DTG.
I see.
So that the mechanism by which the body will normally internalize sugar, DTG may actually, and since DTG may be a bit different from carbohydrate and other INSTI that may not be able to relate with GLUT4 receptor, we might be able, to have alternative INSTI, as something for us. I think something that is important that we look at and look at our data too, whether this is actually happening now. Now that we are actually routinely measuring our patient blood sugar as part of the screening service that we are giving to our patient, we should look inward and look at our data, whether we can actually replicate this. But this data is very important, that there's differences in INSTI use and risk of diabetes.
Yeah, I think it's important that we take a close look. Thank you very much for that insight. Because right now, most of the sugar we're doing in the clinic are random.
Yeah, that is true.
Yeah, so we need to find a way to do fasting and even glycated hemoglobin for those that are at risk, so that we can be able to talk on this and see how it will guide us moving forward. Thank you very much. Thank you.
You're welcome, sir.
Thank you.